Good morning. This is Professor Maha Shahin, Mansoura University. Today's lecture is about central serous chorioretinopathy. Idiopathic central serous chorioretinopathy is characterized by accumulation of fluid resulting in circumscribed elevation of the retina in the posterior pole. The disease was first recognized by Grave in 1866 and was named central recurrent retinitis. Since then, it has been reported under a variety of names, such as idiopathic flat detachment of the macula, central angioplastic retinopathy, and central serous retinopathy. The condition was named idiopathic central serous chorioretinopathy by Donald Gass et al. In 1967. The disease is usually a self-limiting disease. It affects young, middle-aged population. Males are much more affected than females, with a ratio of 9:1 in some studies, meaning that for each affected female, there are 9 affected males. However, in the recent decades, with the more industrialization of the world and women has been added to the working force of the world, the ratio has decreased in some literature to 2:1, meaning for each affected female, there are 2 affected males. Usually, one eye is symptomatic. However, sometimes there are signs in the other eye suggesting that there have been a previous attack. Bilateral, simultaneous, active central serous chorioretinopathy is relatively uncommon. Exclude first other causes of serous detachment of the macula before diagnosing bilateral, active, simultaneous central serous chorioretinopathy. Recurrence may occur either in the same eye or in the other eye. The patient visual acuity is typically 6/9 or 6/18, with improvement by the adding of a weak convex lens due to the acquired hypermetropia from the retinal elevation. The macula is best examined stereoscopically using slit lamp bimicroscopy with Wolf lens or Goldman lens. The subretinal fluid is clear in most of the time. Precipitate may be present on the posterior retinal surface. The elevation is often outlined by a glistening reflex. It affects young, healthy adults between the age of 20 and 50 years. The disease is usually associated with stress. It's more common in males with type A personality. The personality profile are those patients who overthink, obsessive, worry a lot about the future, about caring of their families, about the financial resources. By detailed history, you can detect a stressful event accompanied the appearance of the symptom. For example, losing a case in the court, losing their job, family trouble, divorce. This is usually common in cases of central serous chorioretinopathy. Unusual stress. Experimental models of the disease have been produced by intrascleral injection of indomethacin and repeated injection of epinephrine, which support the fact that stress plays a role in causing the disease. Patients present with a complaint of metamorphopsia or blurring of vision, and sometimes relative positive scotoma and color desaturation. Central serous chorioretinopathy is postulated to occur secondary to leak from choriocapillaris through the retinal pigment epithelium. Features of abnormal choroidal circulation have been well documented, suggesting that choroidal ischemia has a role in the pathogenesis of central serous chorioretinopathy. The disease is self-limiting. Most cases heal spontaneously in 4 to 8 weeks. Recovery of visual acuity occurs in 6 months. After resolution of the detachment, all the fluorescein findings may return to normal. However, mottled hyperfluorescence may be present due to pigment loss and long-standing retinal detachment. Severe visual loss is reported in 5% of cases. Recurrence occurs in 1/3 to 1/2 of all patients, and 10% have 3 or more recurrence. Half of the recurrence occur within 1 year, but it may occur later as up to 10 years after the first attack. How would you investigate a case of central serous chorioretinopathy? First, Amstel grid to detect the central scotoma, the metamorphopsia, then the characteristic picture seen in fundus fluorescein angiography, and with the aid of OCT. First, fluorescein angiography. In 90 to 95% of cases, we have the classic appearance of central serous chorioretinopathy in the form of smokestack appearance, as we see in this slide, or ink blot appearance, as we see in the next slide. On both of them, a pinpoint leak is identified in the early arteriovenous phase. Then, in smokestack appearance, with the progress of the angiogram, there is spreading of the dye vertically upward in a linear configuration. Then, the leakage goes to the side, giving a mushroom-like appearance or umbrella-like appearance. Note in this slide the presence of RPE and atrophic changes that remain the same size, site, and shape all over the angiogram, indicating either a chronic case of central serous chorioretinopathy or a recurrent case. The more common angiographic finding is the ink blot appearance, where we have a pinpoint of leakage in the early arteriovenous phase. Then this pinpoint of leakage increases gradually as a point of ink on a paper. Note in this slide the absence of RPE atrophic changes, indicating this is a recent active central serous chorioretinopathy. It is important to identify the leaking point in the early arteriovenous phase, either in case of smokestack appearance or in case of ink blot appearance, because this point is what's going to receive laser treatment if laser treatment is intended. Long-term follow-up of patients suggests that single episode may lead to slow progressive disturbance of the retinal pigment epithelium at the posterior pole. This slide shows a case of chronic central serous chorioretinopathy, which is associated with substantial underlying atrophic changes. Fluid track downward in a gravity-dependent fashion, giving this gravitational tract appearance. Leakage may occur in the macula, in the peripapillary region, or in the periphery. It is not uncommon to see more than one point of leakage, and this is important if you are going to treat this patient by laser treatment. Sometimes no leaking point is identified. The diagnosis is based upon the clinical appearance. This is a case of central serous chorioretinopathy with the characteristic central serous detachment of the macula with no leaking point. OCT. What are the OCT findings in cases of central serous chorioretinopathy? First, there is an optically empty neurosensory elevation of the macula. Second, sometimes we can see small retinal pigment epithelium detachment. Third, thickened choroid. Fourth, atrophic changes is seen in the retinal pigment epithelium in cases of chronic or recurrent attack. Corticosteroid is one of the risk factors for central serous chorioretinopathy, including intravitreal injection of steroids. So, corticosteroid should be discontinued once central serous is diagnosed. Corticosteroid is contraindicated in treatment of central serous chorioretinopathy. What is the treatment of a case of central serous chorioretinopathy? Most cases are self-limiting and do not require treatment. Unfortunately, most of the treatment modalities can be associated with retinal pigment epithelium tear formation. Laser treatment is used in certain cases. For example, long-standing central serous chorioretinopathy for more than 4 months, or if the patient's occupation requires sharp vision and needs immediate resolution of the fluid, or if one eye is lost due to central serous chorioretinopathy and there is another attack in the other eye. 4 months should pass before considering treatment. Laser treatment induces resolution and lower the recurrence rate, but it does not affect the final visual outcome. Laser treatment is applied to the point of leak, to the pinpoint of leak as identified in the arteriovenous phase of the angiogram. Micropulse diode laser is applied to the retinal pigment epithelium site of leakage and gives good results. Photodynamic therapy. 30 to 50% of the dose used for CNV is used in cases of serous chorioretinopathy, and 50% of the light intensity. This leads to complete resolution even in severe chronic cases and has lower incidence of choroidal ischemia. Other treatment options include anti-VEGF in association with other treatment, use of aspirin, use of beta blockers, use of spironolactone. However, all these options are still under investigation. Differential diagnosis. The following diseases are very important to be considered during examining a case of serous detachment of the macula because of the similarity of the clinical picture and the complete difference in the treatment. First, serous detachment associated with optic disc pit. Both central serous chorioretinopathy and serous detachment of the macula associated with optic disc pit symptomatize in the same age group, but they have completely different lines of treatment. As we see in this slide, a defect in the optic disc is seen in the nasal side. Early in the angiogram, there is hypofluorescence due to loss of the optic disc tissue. Later in the angiogram, there is staining of this area due to staining of fibrous tissue filling the pit. Hyperfluorescence is seen in the macula. This hyperfluorescence is caused by RPE atrophic changes due to chronic serous detachment of the macula. CNV. A small CNV with associated sensory detachment of the central macula may be mistaken for central serous chorioretinopathy. However, the characteristic angiographic filling, the associated angiographic finding help to differentiate. CNV fills in a lacy pattern with leakage within the membrane and then outside the membrane, giving the membrane an ill-defined border. There is association with drusen in age-related macular degeneration, with myopic degenerations, with angioid streaks, history of trauma. In case of doubt, OCT is diagnostic in such case. Harada syndrome. Harada syndrome usually occurs in females, usually bilateral, usually has multiple areas of sensory detachment of the macula and with associated symptoms, for example, headache or tinnitus. OCT also helps in differentiating Harada disease from retinal pigment epithelium detachment. In retinal pigment epithelium detachment, the leakage starts from the periphery and increases towards the center. The leakage starts in the arteriovenous phase, similar to central serous chorioretinopathy, but increases from the periphery to the center, and it is still confined within the same space. Thank you.